Well, I have the privilege of discussing with you the prognosis and management of NASH. Allow me to start with a very short story that illustrates a very important point. Not too long ago, I had a patient come see me for NASH, and I'll refer to her by her initials, MG. And MG has diabetes, central obesity. And so I began to tell MG about NASH and the treatment plan. And after all this, she looks like she's really paying attention, and I'm thinking, wow, she's really getting this. And so after the discussion, she tells me this, Dr. Landaverde, the problem is this. I just don't think I have a problem. I feel fine, I have no symptoms, and in fact, I don't even think I'm overweight, but yet her BMI was 31. So that got me thinking that really the biggest challenge we're faced with nowadays in the management of NASH and NAFLD is this perception that this is truly not a serious health condition, and this really has to change. So my main goal with this talk is to impart on you the importance of NASH, the clinical importance of NASH, and to go over and inform you over some of the treatment plans that, or the regimens that are in clinical trials that will greatly improve our treatment options for these patients. With that, let me get started. So Izzy was diagnosed with NASH, and unfortunately, she also has stage 3 to 4 fibrosis. NASH is considered the progressive form of NAFLD, and unfortunately, up to 15% of these individuals do progress to advanced fibrosis and cirrhosis, and the patients that are more likely to progress, that have the highest risk of disease progression, are those that, as Dr. Porter described, were the diabetics, the ones with metabolic syndrome, and elevated liver enzymes. So once these patients progress to cirrhosis, up to 60% of these patients can then progress to liver failure and or HCC. And the time to progress from cirrhosis, compensated cirrhosis, to decompensated cirrhosis on average is about 7 to 10 years, but this is highly variable, same as from NASH to cirrhosis. They think it's about 15 years on average, but this can definitely vary as much as even early 5 years or so. And so once patients have developed decompensated cirrhosis, even if they're evaluated for liver transplantation and listed, it has been shown that they are more likely to get delisted due to their comorbidities. And ultimately, these patients, up to 30%, do succumb to their liver disease. And so you can see that the prognosis of NASH is highly variable. And for Izzy, unfortunately, she already has NASH in stage 3, so she's in the category of basically having poor outcomes. And so it's of utmost importance to be able to identify the clinical predictors of adverse outcomes in this patient population. Identifying the clinical predictors of mortality and NAFLD, of course, is very important in assessing the prognosis of these patients. In this study that involved 289 patients with biopsy-proven NAFLD, it showed that the NASH patients had a higher risk of liver-related mortality. In fact, this was 9 times higher than non-NASH NAFLD patients, followed by diabetes. I think with all these talks, we're getting the idea that diabetes is a bad player. And it also found that the patients with NASH were predominantly female, had higher liver enzymes, and had higher serum glucose levels, i.e. probably diabetes. So equally as important are the histologic predictors of mortality and NAFLD. And this study then involved 209 patients. Basically, the Janussi and colleagues reviewed the liver biopsy and mortality data of all these patients with the duration of the study to be 146 months. And they found that only significant fibrosis stage 2 or higher was an independent predictor of liver-related mortality, and this was later confirmed by an international, much larger study that involved 619 patients, and the mean follow-up period was 12.6 years. And they also found similar findings that indeed stage 2 fibrosis or higher was considered an independent predictor of liver-related mortality. So in these patients that have risk factors for advanced fibrosis or NASH, a liver biopsy is really key because diagnosing them with advanced fibrosis or NASH will change your clinical management of them. And so equipped with this information, you're more likely to have that kind of discussion with your patient that will hopefully convince them this is a serious health condition, but more importantly, get them motivated to do what you're about to ask them to do. And that is to have weight loss through lifestyle modifications. There have been several studies that have looked at the effect of weight loss on NAFLD. And most of them were small, open label and case series, but what they showed was that, let me go back. What they showed was that there was improvement in liver enzymes, and in those that evaluated histologic response, it showed improvement in histology. So we know that weight loss is beneficial in these patients. Keep in mind, though, the patients that had rapid weight loss had, in some of these studies, evidence that they had increased inflammation. So in patients that have NASH, rapid weight loss is considered potentially harmful. Based on these studies, the NAFLD guideline recommendations are such that loss of at least 3 to 5% of body weight appears to be necessary to improve steatosis, but more like 7 to 10% weight loss is needed to improve necroinflammation, that is NASH. And exercise alone in adults with NAFLD may reduce steatosis, but its ability to improve other aspects of histology at this time remain unknown, but we definitely think it's beneficial. So what about those patients that can lose weight and they are candidates for bariatric surgery? There have been several studies that have evaluated bariatric surgery in patients with NAFLD. And I just want to point out that there's no randomized controlled trials evaluating bariatric surgery in NAFLD patients, but these studies that we have here and several others have shown that there's decrease in steatosis, inflammation, and liver enzymes, and the results on fibrosis have been highly variable. Keep in mind that a couple of these studies did show worsening fibrosis, especially early on after the bariatric surgery, which stabilized or improved over time. So in patients that have advanced fibrosis or early cirrhosis, make sure that that you counsel them that there may be a risk that they can tip over to cirrhosis and hepatic decompensation. So in addition to weight loss, we believe that pharmacologic management of NASH is very important in many patients. There have been several therapies that have been evaluated in NASH. I'll start with vitamin E. There have been several clinical trials that have evaluated vitamin E, and based on this data, we know that vitamin E at a dose of 800 units a day, all in one time, Q-day, has been shown to be really the first-line pharmacotherapy for the patients that are non-diabetic and have biopsy-proven NASH. Outside this patient population, vitamin E is not recommended. There's a lot of interest in the lipid-lowering agents, as a lot of these patients do indeed have dyslipidemia, and most data has been on the statins. And most of these studies, unfortunately, have been very small and pilot studies. But what we see is that until that we have better randomized controlled trials with histological endpoints that prove the efficacy of statins, at this time we cannot recommend statins to specifically treat NASH. However, statins can definitely be used to treat dyslipidemia in patients with NAFLD and NASH, because given the lack of evidence to show that these patients with NAFLD or NASH are increased risk of serious drug liver injury, and we know that they definitely benefit from managing their dyslipidemia. Insulin resistance is very central to the pathogenesis of NASH, and so there's a lot of interest in evaluating insulin sensitizing agents such as the PAR gamma agonist. There's been a lot of data on this class, and we know that most of it, unfortunately, is only for pioglitazone, but based on this, and all the studies, pioglitazone can be used to treat steatohepatitis. There's a question mark there because, unfortunately, the long-term efficacy and safety of pioglitazone in patients with NASH has not been established. And as we learned earlier, there's some potential long-term side effects. In addition, though, the patients that were evaluated in these clinical trials were non-diabetics, and so we typically recommend pioglitazone in patients with diabetes. So it's something that you may consider, but at this point, I think most hepatologists are a little hesitant. What about the newer agents? We heard about them earlier, such as the GLP-1 and the DPP-4 inhibitors. There's limited data on these newer agents, and most of them are pilot studies, but the data is really encouraging. The GLP-1 analogs have shown to improve steatosis and NASH histology in pre-diabetics, while the DPP-4 inhibitors have shown decreased liver enzymes and improved liver histology. So hopefully we'll have more clinical data on these agents, but given the limited data at this point, we cannot recommend them for a specific treatment of NASH. As you can see that so far the available treatment options for patients with NASH are quite limited, but the good news is that there are several new therapies on the horizon that will definitely greatly increase our treatment options for this patient population. This is a list of the new regimens that are in clinical trials, and actually there's quite a bit more, but I'm going to go over some of these, and the ones that I'm not, I'm going to highlight at this point, such as the fatty acid bile acid conjugate, Aramco. This is very important, as it's been shown to decrease liver fat content. The dual inhibitor of chemokine receptor 2 and chemokine receptor 5. This therapy is involved in leukocyte trafficking, and therefore it's very important in decreasing inflammation. And the probiotics such as VSL number 3, there's a lot of good data coming out, and this basically is addressing or targeting the gut microbiota dysbiosis, which is obviously a very hot new topic. With that, let me get started with these new regimens. Obeticholic acid that we heard earlier today is a modified bile acid and farnesenoid receptor agonist, and it has been shown to decrease fibrosis by several mechanisms, including decreasing stellate cell activation. It decreases also inflammation by downregulating macrophage function and therefore decreasing inflammatory factors. It has a very important function in bile acid homeostasis, and that's why now it's been approved for PBC. The FLINT study is a phase 3 trial that evaluated obeticholic acid in patients with NASH. It included 283 patients, and patients were given the obeticholic acid 25 milligram a dose, which is higher than what's recommended for PBC patients. These patients were followed for 72 weeks on treatment and then 24 weeks off treatment. The primary endpoint was liver histological improvement, defined as decrease of the NASH score by greater than 2 points with no worsening in fibrosis. And so obeticholic acid was able to achieve this primary endpoint in 46% of the patients, compared to 21% of placebo, and that was statistically significant. It also was able to significantly improve fibrosis and NASH resolution as compared to placebo. The adverse events were few, but the most common one was pruritus. 23% of the patients developed pruritus. However, the majority of them only had mild to moderate pruritus. Only one patient stopped therapy because of this. The rest of the adverse events were not considered to be due to therapy. What was even more interesting about this study is that they did a sub-analysis using obeticholic acid in patients with high risk for disease progression, which are the patients that we really, really care most about. And they were able to identify 3 high-risk subgroups based on the previous literature. One of the groups was with fibrosis stage 2 or stage 3, and those with fibrosis stage 1, accompanied by one or more of the various factors that have been shown to be associated with higher rates of fibrosis progression that I covered earlier: diabetes, obesity, and elevated ALT. Obeticholic acid was associated with high rates of NASH resolution in this very high-risk subgroup. In 18% of the patients, they were able to resolve their NASH compared to 5% of the placebo. And this high rates of NASH resolution were seen in all three subgroups. In addition, it also improved fibrosis in 39% of the patients compared to 21% in placebo, and that was statistically significant. And these high rates of fibrosis improvement were also seen in all three groups. And this is particularly important as you recall that advanced fibrosis is an independent risk factor for liver-related mortality. So there's been previous trials that have evaluated the PAR agonist, and unfortunately, they have not panned out in the clinical trials. However, except for pioglitazone, which is a PAR gamma. However, now there's new interest with the dual PAR alpha and delta agonist because they target more areas related to NASH, such as the insulin resistance, inflammation, fibrosis. So there's great new interest in this new class of therapy. This is the phase 2 randomized controlled trial evaluating the dual PAR alpha delta agonist GFT505, which is now elafibranor in NASH patients. And elafibranor showed to have significant effect at a dose of 120 in NASH resolution using this new recommended definition that accounted for confounding factors. This is really exciting data because now that gives us another agent that can potentially help us in treating these patients. We await the final results. Simtuzumab is another therapy that is antifibrotic. It's being studied in several phase 2 trials and is a humanized monoclonal antibody that inhibits cross-linking of collagen in pathologic stroma by decreasing the lysyl oxidase LIKE-2 levels. And this has been studied in idiopathic pulmonary fibrosis with good results. So we're very excited about this because this directly targets fibrosis because, again, this is what we really need to do to decrease the risk of these patients progressing to cirrhosis. And so how do we manage our NAFLD patients in 2016? Well, you could start with the liver biopsy and those that have clinical risk factors for having NASH or advanced fibrosis. If the liver biopsy shows that they have just simple steatosis with no evidence of significant fibrosis, then these patients are counseled on lifestyle modifications because you still want them to be as healthy as possible, but refer back to their primary care doctor for management of the risk factors of metabolic syndrome. If they indeed have histologic NASH or evidence of fibrosis, then we definitely want them to continue lifestyle modifications to have gradual weight loss of about at least 3 to 5%, if not 7 to 10%. If they're non-diabetic, they can be started on vitamin E. And if they're diabetic, consider pioglitazone. If medical treatment is unsuccessful, then consider referring them to the many RCTs that we have available on the new agents. And consider bariatric surgery for those patients who meet criteria. With that, I would like to leave you with these concluding thoughts. NAFLD, i.e. NASH, really has tremendous clinical, economic, and quality of life burden to the patients and to society, and this burden, unfortunately, is only growing at this time. So increase in awareness is really key. NASH is really the progressive form of NAFLD, and in the setting of the metabolic syndrome and diabetes, it can have adverse outcomes. Histologic fibrosis stage of 2 or higher is predictive of liver-related mortality. So in these patients that have risk factors for advanced fibrosis, a liver biopsy should be considered. The pathogenesis of NASH is complex. It involves multiple hits, and our current therapies do target a lot of these hits, but unfortunately this time they're quite limited. But the good news is that we do have several clinical trials of new agents underway, and so we hope that our treatment options will definitely increase in the very near future. I want to finish my presentation with a very, very quick story before Dr. Wells comes with the hook here. It's a success story, really. I had a patient come see me 6 months or so after implementing lifestyle modifications, and she had lost the necessary weight, her liver enzymes had improved, and in fact, her ultrasound elastography showed decreased liver stiffness, so she was very happy. I was a little curious how she had done this, so I asked her how she had accomplished all this, what had motivated her to do all that, and she told me that basically 2 things. That one, that I had taught her something new at the initial visit, and I had made it sound that it was possible for her to accomplish this, so I had a little proud moment there. Later on, however, I read that likely the reason why she was so motivated is because when you learn something new, the dopamine levels in your brain increase. And so we know how that feels. And so I hope with this presentation, the dopamine levels in this room have increased. Thank you.
Thank you, Carmen. Exciting times in the world of NASH soon to come. So Izzy was counseled by Dr. Landaverde to lose 10% of her body weight due to her advanced fibrosis. However, she was only able to achieve 3% loss despite reduction of her intake to only 1 meal per day. She was pretty frustrated with her options. She didn't want to eat the things that were good for her. She craved all the things that she was not supposed to eat. So she went back to speak to Dr. Landaverde, who suggested that she might want to try probiotics because this has more data coming out about its benefits in NASH patients. She was also referred to a dietitian. So with this, Dr. Musi is going to come enlighten us on metabolic effects of endotoxin signaling.